The next talk comes from, it's a cardiologist's point of view on the same topic. And it comes from Professor Weber, who is a director in cardio-rheumatology clinic, associated physician, and he's an assistant professor in Harvard Medical School. So let's listen now, the same topic from the cardiology point of view. We're ready to proceed, please.
And thank you for the opportunity to talk about cardiovascular risk and lupus. I'm giving the cardio-rheumatologist perspective. I wish I could be joining you all virtual during the actual day, but I'm pre-recording this due to being on clinical service. But I am so excited for this conference once again. That is such an amazing, amazing conference, and also so many topics near and dear my heart. So my name is Brittany Weber. I'm the director of the Cardio-Rheumatology and Dermatology program at the University of Texas Southwestern Medical Center, and have recently transitioned from the Brigham and Women's Hospital. So you'll see a lot of my research today where we've done in my prior rheumatology labs at the Brigham. So here are my disclosures, including my grant funding. So as a cardiologist that's been interested in immunology since I was in high school, everything has truly changed. Indeed, we have the proof of principle landmark study in 2017 that demonstrated for the first time that a pure anti-inflammatory biologic that blocks IL-1 beta led to a reduction in cardiovascular events among patients with cardiovascular disease. This was the CANTOS trial. And we've had increasing data of the role of colchicine in cardiovascular risk reduction. This is the LODOCO trial that showed a very significant cardiovascular risk reduction among patients with stable coronary disease. And I will say for us in the United States, the 2023 was a really exciting year because this was the very first time that the FDA approved an anti-inflammatory therapy for reducing cardiovascular events. And of course, we're still continuing to learn the beneficial settings where colchicine is more and less beneficial. But again, it marks an important moment where we are now recognizing the importance of inflammation. And so I would argue to all of you today that immunology really sits at the pillar here. So it really integrates in all forms of medicine. And I just gave you an example on the left axis of cardioimmunology. So the increasing appreciation of the role of the immune system and the general cardiology patient. But where I sit and breathe and where we're here talking about today as a cardio-rheumatologist. So that is taking care of patients with systemic inflammatory diseases. And lupus is one of the most common diseases that we see in the clinical practice, which has diverse manifestations of cardiovascular involvement. So let's just get right in. A lot of this will be review for many people in the audience, but what is systemic lupus? Well, this is a chronic systemic autoimmune disease that's characterized by inflammation and immune-mediated injury to multiple organ systems. There's a wide variety of manifestations. It's predominantly female, about 88% female, 3.4 million are affected globally. And the pathogenesis is complex. It's believed to be elevated type 1 interferon and autoantibodies against nuclear antigens. There's also very important genetic predispositions and environmental triggers. And these are just many of the different rashes one can see in lupus here on the right. So when we think about cardiovascular disease, there's a very complex interplay between immune-mediated inflammation, autoantibodies, and pro-athogenic factors that are contributing to this accelerated risk. I really like this figure here on the left because it shows you all the traditional risk factors are still very important, but then it shows you all the lupus-specific risk factors we need to be thinking about here on the right. And we've known for decades that patients with systemic lupus have increased rates of atherosclerosis. This was a paper published in the New England Journal of Medicine now 22 years ago that demonstrated among asymptomatic individuals with lupus, they had much higher rates of atherosclerosis detected by CT. So this is coronary artery calcium at all age groups. So less than 40 all the way greater than 60. And so when we think about the cardiovascular manifestations by which our patients present to us, so here's my perspective, is we have to think about the scope of the problem. I like to put it into buckets because there's so many different ways, the manifestations. We've got the vasculature. We talk and we think about a lot about accelerated atherosclerosis, which is very important. We also have increasing data that these lupus patients can have high prevalences of microvascular dysfunction. Frequently involvement in lupus is pericardial disease with pericarditis. You can have valvular disease, myocarditis, heart failure, as well as electrical complications. So one important point is that we know that disease-specific risk prediction tools are needed. We know in general for most of our autoimmune disease that the risk prediction tools that we utilize for all of our other patients, they underestimate risk. Indeed, in our ACC-AHA calculators, the pooled cohort equation, we now recognize this as lupus is a risk enhancer. So this is just one example of, we did a study back at the Brigham in Dr. Consenbader's lab. This was led by a brilliant rheumatologist in Calgary, Dr. May Choi, where we looked at our own cohort and we took the standard model we'd use in clinic, we adjudicated outcomes, and we said, what would those lupus-specific risk factors be if we were to build a model to better predict cardiovascular outcomes? And this is the SLE risk score that we developed. And this is actually now online. I can send anybody the link where it's a calculator you could all use in your practice. But what we observed when we did this study is that we found these are the lupus specific risk factors that came out in our model: disease duration, activity, double strand DNA, lupus anticoagulant, anti-Ro, low complements, and creatinine. And importantly, this identified 3-point-fold more lupus patients as moderate to high risk. And not surprisingly, because our risk calculators underestimate risk in young, this was much better at predicting risk in young females. So I told you on the slide before that we have increasing data of microvascular dysfunction. And so when we think about our patients with lupus and what are important manifestations and correlates of risk, we've done work on looking at microvascular dysfunction. And so one common theme among our patients with autoimmune disorders is that it's prevalent, and it's also been demonstrated to be prognostic. This is a study we did back in my laboratory at the Brigham, where we took our lupus cohort that was referred for perfusion PET. So this is one of the gold standards for measuring myocardial blood flow for an assessment of microvascular dysfunction. And we matched them to controls by age, gender, and risk factors. And what we observed was that our patients with lupus, they had much more prevalent microvascular dysfunction. This was using the myocardial flow reserve or the coronary flow reserve, what we get from a perfusion ammonia PET scan. And we also demonstrated there was a relationship with disease severity. So this is SLE here. And the more severe a patient's disease activity was, there was a relationship, you can see here, a negative relationship to the flow reserve. So lower levels would indicate higher levels of microvascular dysfunction. We also did a study, as well as Dr. Attila Feher at Yale. They published a similar study at the same time. And these two studies both looked at patients together with immune-mediated inflammatory disorders and said, is it prognostic? So we know that having CMD in the general population is associated with worse outcomes, but would that hold true in a patient with lupus? Was not specifically studied. And that's important because our patients can have valleys where they're more stable and flares of inflammation. And what this paper demonstrated was that these three diseases, lupus, RA, and psoriatic disease, when you had coronary microvascular dysfunction, it was associated with worse outcomes, including survival and MACE. And similar colleagues at Yale had similar findings. So I would challenge all of us that I think coronary microvascular dysfunction is an important thing to be thinking about in clinical practice. It's both prevalent, prognostic, and we can utilize that when we're thinking about biomarkers for understanding whether certain therapeutics improve vascular health. We also know that patients with lupus have an increased risk of heart failure. This was a very nice study done by the Danish Health Registry. They have a beautiful health registry where they can look at large number of patients. So they were able to look at 3,400 lupus patients. So, right, I can't do that in the US. So that's a very large number of patients, and they matched them to 13,000 controls. And what they described in this study that was published in JACC a few years ago was that patients with lupus had a twofold greater risk of developing heart failure compared to controls, with a higher mortality among those patients who then went on to develop heart failure. So in terms of all the manifestations, we have to be remembering about heart failure, and more work is needed in this with lupus. So how can we move the needle forward? So I would challenge all of us, and I think most of us would agree with the theme of this conference, is there's an incredible role for multimodality imaging. This was a statement that I did with both Dr. Mavrogiani and Dr. Mukherjee and other colleagues, a JACC scientific statement where we looked at the role of multimodality imaging. And what really we described is that by integrating multimodality imaging, we can improve the screening, the detection, and the serial monitoring of cardiac function. And so we go through all the different modalities and how each of those can be used to think about all the different manifestations. However, one important point is lack of guidelines leads to variable assessment. And this is really where all of us here today really have to be pushing the field forward by ongoing efforts in this. And why is that? Because we have the expansion of imaging tools, right? We are much further beyond the exercise ETT and echocardiography, although these are very commonly used and very important modalities we utilize in practice. You can see here that we can dive much deeper into pathophysiology by other advanced imaging techniques. I already discussed the role of my stress PET for microvascular dysfunction and perfusion. This is the beautiful vasculature of the heart shown here. Coronary CT, we're getting more advanced. Now we can also look at metrics of coronary inflammation by the PCAT, or the fat attenuation index, which is one of the radiotranscriptomic methods developed by Oxford, which has a lot of increasing data coming out. So a very important role for coronary CT. And of course, part of the theme of this conference is the role of cardiac MRI. And you can see here, we get so much data from cardiac MRI. We can get stress perfusion from myocardial blood flow, and we get myocardial and pericardial structural assessment. And so this is my patient shown here with lupus pericarditis. So I already mentioned this, but the current challenge is that integrating imaging will improve our outcomes, but the lack of guidelines does lead to variable assessment. So this is just two examples of work of patients with lupus. This was a patient on the right here that presented with acute chest pain, where the coronary CT revealed coronary arteritis. These are going to be coming out in the new chapter of Braunwald that's being currently in press, that I've had the opportunity to work with the brilliant Dr. Youngstein and Dr. Libby with. And we talk a lot about imaging and show a lot of cases. On the left here is my patient with lupus with recurrent pericarditis, who was not getting relief with multiple different lupus-specific therapies. And ultimately, we transitioned her to an IL-1 blocker, which is not a typical lupus therapeutic. And we demonstrated improvement in her symptoms and in her imaging assessment, where her LGE of the pericardial had actually improved and resolved. So showing us how we can actually utilize this in clinical practice to guide our therapeutics in our patients. So thinking about moving the needle forward. So as a cardiologist, I do believe we need innovative solutions for identifying risk. This is one example as where we said, well, what about data that exists already in the medical record? So we all know that there's increasing use of AI in clinical practice, and there's multiple ways one can now detect calcium by AI algorithms from chest CTs that were ordered for non-cardiac indications. So this is a study we set out at the Brigham to address, where I took the 3 common diseases I frequently study, so lupus, psoriasis, and rheumatoid arthritis, and we collaborated with a company that's an FDA-approved technology for CAC by an AI method called Nanox. And we identified patients that did not have coronary disease, that had chest CTs for other reasons at our institution. And we analyzed to assess what is the prevalence of coronary calcium and what's the prognostic significance. And this is the central illustration. This is excited to tell you it's finally in press, so we'll be online soon. But what we observed was that this is data, again, that's existing in our medical record, that having the presence of atherosclerosis was common. About 50% of the cohort had some levels of CAC, and not surprisingly increasing relationships between outcomes to the severity of plaque. But importantly, even low levels of coronary calcium, so that very mild threshold, so a score of 1 to 99, that was associated with risk levels we think about secondary prevention, highlighting this notion that our patients with lupus are inherently higher risk. So this is where we have to be thinking about how to use imaging for innovative solutions to get our patients on prevention therapies. What are other ways we can integrate imaging to improve cardiovascular outcomes? This was a study I got to be a part of by the brilliant Dr. Linder at UVA, as well as Dr. Abate. He's also speaking in this conference, where we looked at patients at UVA with lupus, and we looked at where they had echocardiogram and asked the question, can we identify clinical predictors of impaired LV systolic and diastolic function by advanced echocardiographic analysis? And this is the central illustration. So again, reference here if anybody would like to take a look at this paper, because I think it's very interesting, because what we observed was that reduced global longitudinal strain, it was common. So 40% of the patients with lupus, it was associated with having heart failure symptoms and increasing disease severity. And we also saw very interesting associations of the global longitudinal strain of the left ventricle with RV function, diastolic function, and left atrial strain impairment. Really thinking through what is the possible immune basis driving this conglomerate of changes that we're seeing. Also an interesting relationship we saw with pericardial involvement. So really a cool study that really just drives the need for future ongoing efforts in the field. And so that leads me to another manifestation, is that we need to be remembering with our patients with lupus, there's an association with pericarditis. This is just showing you all the different autoimmune diseases that can present with pericarditis. And we should be remembering that when our patients with lupus present to us with chest pain, we should keep pericardial and disease and pericarditis in our differential. And this is a very common thing I actually see in my patients with lupus. And the field is actually rapidly advancing in terms of idiopathic recurrent pericarditis, because we're having increasing appreciation of the role of the IL-1 NLRP3 inflammasome pathway. And that's really what's showing you about this shift in recurrent pericarditis. Many people listening here probably have seen the new guidelines that just got released from ESC for myocarditis and pericarditis, and it goes through all these new advancements. So this is the biology here, that something is going to incite injury to your pericardium. You get the pericardial injured cells will activate IL-1 alpha, activating the inflammasome. You're getting this auto-inflammatory loop here, where you go and getting auto-regulation feedback, and you're getting release of IL-1, producing IL-6, COX, all the downstream mediators. And one would say then, well, if this is the pathogenesis, does blocking IL-1 block this process? And for the idiopathic patient, again, this is not our patients with lupus, there's been increasing amounts of data across 3 different biologics that block IL-1 alpha and beta, demonstrating the dramatic reduction in recurrent pericarditis episodes patients get when they're treated with IL-1 blockers. This is the AirTrip trial in Europe, the Rhapsody trial, and the Goflicab trial was the most recent. And indeed, this led the United States to approve rilonacept in the middle. This was the US-based trial, is the first anti-inflammatory therapy for recurrent idiopathic pericarditis. But again, even though a lot of us have anecdotal evidence of it working in our patients with lupus pericarditis, it still remains to be studied adequately, but just shows you how complex our patients with lupus can present to us, and how they may get better relief with certain therapies based on their cardiovascular manifestation. And this was a study that I got to be a part of a year ago, which is the International Position Statement, where we really walk through the new advancements of the biology of inflammation, as well as the role of imaging, particularly the role of MRI, and how we can utilize MRI and the advancements in immunology to really guide our therapeutic systems. And so this is a great review article. There's also the new guidelines that are also an amazing review article for many people who want to learn more about this field. And so now I'm going to present to you another one of my patients with a different manifestation, and then try to wrap up. So this is my 63-year-old female with active lupus who presented with shortness of breath. This was a number of years ago. Here's her lupus history. She had a very complex lupus history, multiple manifestations of her lupus. Her medication history, again, so important to be asking our patients this. Long history of steroid use. She had failed multiple agents, including shown here. She'd been on hydroxychloroquine for over a decade. She did have her dose reduced after she developed some cataracts, and she had recently started Benlysta, so targeting the B cells. So here's her echocardiogram at the time. So in the sake of time, I will tell you, this is not a super happy left ventricle, as you guys can probably all appreciate. We can see here the LV is mildly dilated, and there's biventricular dysfunction with diffuse hypokinesis. Here's her EKG. In the sake of time, I can just tell you guys here, you can probably see this, but there was sinus rhythm with bifascicular block, as well as evidence of LVH. So conduction system disease. Again, the loopologist in here maybe guess what I'm thinking here, but we're all kind of saying, what could the etiology of this be? So what do we do? Well, I saw her in clinic, actually. I still remember this. This was right when I started my cardio-rheumatology clinic at the Brigham. And so she got referred to me, but when I saw her, she was very ill appearing and definitely had evidence of significant heart failure with volume overload. So she got admitted to the hospital. You can see here her physical exam is just corroborating her ongoing congestive heart failure with elevated filling pressures, crackles. She was warm, which is a notable point. She had a positive S3 on her cardiovascular exam. And so as she was admitted to the hospital, these are her labs. You can see her CRP, her complements, and she had ongoing evidence of the autoantibodies. So I just told you that she had been admitted at this point. And so here's her cardiac MRI. I know we have all expert readers in here. I think I've got another image here showing you the late gadolinium enhancement. And so just in the sake of time, I will tell you again, it corroborated her EF being down at 30%. She had akinesis of the mid to distal anterior wall and apex and a medium amount of scar that was really read as being consistent with a prior MI. There was no evidence of active inflammation, which is important. So you may say, what did you do next? Well, of course, we're ruling out coronary disease with a presentation like this. So here's her coronary angiogram. I'll just let this play for a second. But what you're not seeing is something that would be so significant to really be describing the findings. You are seeing some mild coronary disease, but nothing to really explain the extent of her presentation now. So now putting this together, we've got a 63-year-old female with subacute progressive onset of heart failure, evidence of biventricular dysfunction, conduction system disease, and non-obstructive CAD on her coronary artery calcium. So what does this point to? Well, this was ultimately a diagnosis of hydroxychloroquine-mediated cardiomyopathy. And again, this is rare, but it's a very important thing we all have to be thinking about because it's associated with poor prognosis. It's associated with long duration, high daily doses of hydroxychloroquine. Conduction disturbances are common. We can see a host of different echo findings as well as cardiac MRI. We often see LVH with varying degrees of dysfunction. The diagnosis is a biopsy with electron microscopy. You can see here the classic lamellar and curvilinear bodies we see on EM shown here. And what do? Well, we take off the drug and we treat them aggressively for heart failure. There is some data that if you catch it early, it is reversible, but oftentimes when we see these patients, it's actually not reversible. So I do think that anti-malarial induced cardiomyopathy is under-recognized, and this is a missed opportunity for how we can detect our high-risk patients. These are just two studies in my lab at the Brigham with Dr. Constanbader. This is the lupus fellow, Dr. Paul Kim, who's worked with us this year. And these are two studies where we try to address this. Do we screen for, do we miss AMIC, so hydroxychloroquine cardiomyopathy? And what we looked in our own institution, the kind of take-home point was that high-risk patients are not receiving adequate non-invasive screening, and we're needing more in standardized protocols. We also looked at the clinical and laboratory features associated with biopsy-confirmed AMIC. And what we also looked here, again, very few patients were actually getting endomyocardial biopsy. And the takeaway was that we're really having missed opportunities for our pre-biopsy screening, and we're often omitting electron microscopy on the biopsies if it's not in the top differential. And so these are going to be presented at the ACR in the scientific sessions in a few weeks. So if any of you will be there, please take a look out for Dr. Paul Kim's presentations. But what our take home is that this is under-recognized in long-term users. We need imaging modalities and biomarkers to moving forward. So scientific research in this, so we can develop standardized risk-based protocols. This is just an acc.org review that we did on this. If anybody wants to learn more, we talked about preliminary screening recommendations. Again, we need more data in this, but this just walks through what are the risk factors so the clinician is thinking about this, and how can one think about drug monitoring for asymptomatic patients with imaging or biomarkers, and what are the things we would look at when we're starting to see progressive cardiovascular findings. This was led by a brilliant now cardiology fellow, Dr. Helene DiGiorgio, excuse me, who led this. So please take a look if you're interested. And so with them, I'm going to start to wrap up. So I hope you got a flavor for cardiovascular risk in lupus from the cardiology angle of all the things I'm thinking about when I'm seeing these patients in clinic. We've got a lot of building blocks to move forward for prevention. This is one of our unpublished figures from the US-based working group. And what we're showing here is that there's a huge role for imaging in our assessment of patients, understanding the targets of inflammation, prevention. It really requires close collaboration between all of us here today, including radiologists, imagers, rheumatologists, dermatologists, cardiologists, our pharmacists. And we need to really push forward the future of the field, including not only the research and educational resources like this conference, but also thinking about training our future generation. We are growing globally. We have an NYU conference we do every year. It's virtual, or it's in person, but there's a virtual component. So please email me. This is at NYU. I co-direct this with Dr. Michael Garshnik. Many people here today may have gone to the ESC 2023 cardio-rheumatology course. It was spearheaded by Dr. Mavrogiani that I got to attend. Every year there's a Toronto symposium. I was just at it last week. It was a fantastic symposium. As many people on the call know, we host a virtual conference series every month. Please email me. I can get you on the listserv. We just had one this week. Fantastic cases. We still have too few of clinics in the United States. We also have the brilliant UK Cardio-IMID partnership, which is doing a lot of research in clinical and educational efforts and furthering the cardio-rheumatology in the United Kingdom. These are two amazing fellows that were able to come visit me at my institution last year and work with me. And with that, I just want to acknowledge everybody for the research I've shown you today. Again, everyone at my new institution, all the prior colleagues and mentors at the Brigham, including Karen Constanbader, who I really learned so much from, is an expert in lupus, and we continue to do research together. This was, many people here on this call may be on here, but this was me with Dr. Mavrogiani at ESC 2023 after that cardio room course, and these are all my funding below. So please do reach out if you have any questions. I wish I could be there online with you on Monday, but thank you for this opportunity.
Okay, this was an excellent presentation. I think it was very comprehensive and extended information on the imaging on lupus, and all of us, I think that we have gained new knowledge on the use and the value of the imaging modalities. So on this point, I have to ask if there is any comment from the audience. Any comment from Dr. Mavrogiani, from Dr. Mavrogiani?
I think this was an excellent talk and raised new data, and the issue about cardiac toxicity of hydroxychloroquine is really interesting and important. And we need to further gain more data.
I have a comment.
Yeah.
Indeed, it was an excellent presentation. Brittany is always very exciting person in presenting new things, so she's well organized and she did her best, and we really enjoyed it. I'd just like to emphasize that for two diseases, systemic sclerosis and systemic lupus erythematosus, in our ESC document recently published a couple of years ago, we emphasize the need to have a reference CMR scan in both lupus and systemic sclerosis, just because maybe it will be cardiac involvement early before the rheumatic disease diagnosis. And this is really important just because we need to have a basic CMR evaluation before we start giving medication. Provided that there is a risk from medication, the risk from the disease itself, the risk of pure lupus and concurrent other clinical risk factors. So it is really important to have a basic essential risk, and it was a common agreement between cardiologists and rheumatologist participants in this paper. I just have to mention that.
Of course, of course, of course.
Just because the echocardiography does not give always the information we need, and even the strain information we can take them after the development of diagnosis of autoimmune rheumatic disease. In the meanwhile, tissue characterization alterations have taken place already. So if we really want to prevent cardiovascular disease, we have to use tools that can give very, very, very early information about the heart. And these tools are mainly CMR, cardiovascular magnetic resonance, and in some cases, potentially cardiac CT. Of course, if you have a clinical scenario which suggests this examination, because don't forget it is an examination with radiation, and we cannot repeat it every year, even if it's not very high, the amount of radiation anymore. So just keep it in mind. I mean, echo is not enough. It's very important, of course. It's an everyday tool, and we have to use it. I encourage all my patients to have an echo every year, as EULAR recommends. However, we should also move in parallel to more sophisticated modalities that can provide very early clinical information.
Yes, and if you don't mind, Dr. Marogeni, just to add on this, on what you're saying now, that just to inform all doctors that are not very involved in cardiac MRI, that because, like this lecture, there was no, unfortunately, we didn't have, like the chance to get this lecture today, that the new modern and advanced cardiac MRI sequences, they give us information about edema that we didn't have this chance, we didn't have this benefit when we having MRI some years ago. So apart from the stereo imaging, we have like the T1 mapping, we have like T2 mapping. So we have several sequences that we can detect accurately edema. And based on that, we can have an earlier detection of inflammation, myocardial inflammation, just to inform all doctors that are not involved that we don't need any gadolinium, we don't need any contrast for having a test like this. So there's no radiation, no contrast for having T2 measuring, a T1 measuring, and edema sequences. Yes?
And the other thing is about the treatment. In all patients I examine, I see that they take anti-inflammatory NSAID medication, anti-inflammatory medication, and then they move immediately to steroids without any treatment with colchicine, which is, I think it's a pity, because colchicine is very efficient in both myocarditis due to autoimmune and due to non-autoimmune factors. So cardiologists should remember this old drug, which is very efficient and gives really tremendous results, except, of course, we have to take care of gastroenteric complaints of the patients. If it happens, we'll see. However, it is very efficient and cheap everyday drug that should come again in use by cardiologists.
Agree. Totally agree. Totally agree.
And it's good not only for the pericardium, but also for myocardium. So it's a good opportunity, because in many cases, there are not two different entities. In most of cases of pericarditis, there is also a mild involvement of myocardium, which is something that cardiologists do not keep always under consideration. No, we should change this attitude. We should teach our friends and people and students to learn more about this and to appreciate this condition.
Of course, and we can see, like whoever is involved to cardiac MRI can see what exactly you said now very often, the myocardial involvement in pericardial disease.
Okay.
So is there any other question from the audience? Does the control let us know, update us? This is the last chance. So whoever was a little bit shy, you can ask.
Okay. So then go to break.
Okay. So